Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Commonwealth Fund on Medicaid ACO programs, promising results from leading-edge states. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you'll take a moment to do this. I'll now turn the webinar over to Tricia McGinnis, Vice President at the Center for Healthcare Strategies.
Thanks, and welcome everybody to today's webinar on promising results from Medicaid ACO programs. My name is Tricia McGinnis, and I'm Vice President of Programs here at the Center for Healthcare Strategies. We are really excited that you've joined us here today for our webinar, where 3 leading-edge states will share results of their Medicaid ACO programs and describe lessons that they've learned along the way and how they're planning to incorporate those lessons into future iterations of their ACO models. A big thanks goes to the Commonwealth Fund for supporting this webinar, as well as related work around the Medicaid ACO Learning Collaborative that we've run now starting its 5th year. On today's agenda, I'll introduce the speakers for today's webinar and give a quick overview of the Medicaid ACO landscape. We'll then dive into the heart of the webinar, which are results from the Medicaid ACO programs that Minnesota, Oregon, and Vermont have launched over 3 years ago. After that, we'll open it up for questions from the audience. I'm happy to be joined today by a few folks that you see here. First is Pamela Reilly from the Commonwealth Fund, Assistant Vice President overseeing their work in delivery system reform. Matt Spang, who's Manager of Care Delivery and Payment Reform for the Minnesota Department of Human Services, here to talk about the Integrated Health Partnerships program that they are running. Tamar, Director of Systems Transformation Center at the Oregon Health Authority, who's here to share information around the coordinated care organizations in Oregon. And finally, Alicia Cooper, Healthcare Project Director at the Department of Vermont Health Access, who's going to share information on their Medicaid Shared Savings Program. All 3 of the states are alumni of the Commonwealth-funded Medicaid ACO Learning Collaborative that CHCS runs, and we are really thankful for their time in sharing the results of their programs and the lessons that they've learned to date. Briefly, for those of you who may not be familiar with the Center for Healthcare Strategies, we are a nonprofit organization that works with Medicaid agencies, health plans, providers, and the Centers for Medicare and Medicaid Services to improve the health of low-income and working-class Americans. We do this under 3 priority areas. The first is supporting broad-based state efforts to transform how care is paid for and delivered to consumers. The second area is integrating services for people who have complex care needs. And the third is advancing access to health care coverage and services. We provide technical assistance, disseminate emerging early lessons and best practices, support Medicaid leadership capacity development, and support peer-to-peer learning opportunities that are so critical for cutting-edge innovative issues. Through funding from the Commonwealth Fund, as well as some other funders, for the past 5 years, CHCS has worked on a variety of projects to support states in advancing their Medicaid accountable care organizations. While not all Medicaid providers may be ready to be part of an ACO, we think that as a payment and delivery system reform strategy, that ACOs hold tremendous promise for enabling providers to reap the financial rewards from delivering high-quality, efficient care, and for low-income consumers to receive more effective, better coordinated care that will lead to better outcomes. At a programmatic level, we also think that ACOs can be a critical strategy for effectively managing Medicaid budgets. And with that, I'll turn it over to Pamela Reilly from the Commonwealth Fund for a few remarks. Pamela?
Thank you, Tricia. Hello, everyone, and thank you so much for participating in today's webinar. As Tricia mentioned, our work with CHCS on the Medicaid ACO Learning Collaborative is part of our Delivery System Reform Program, which aims to create high-performing health systems for vulnerable and high-need, high-cost populations. And for the past several years, we have decided to focus on ACOs as a model which has tremendous potential not only to improve the quality of care for vulnerable populations, but also provides an opportunity to incorporate other services needed by this population, such as behavioral health services, social and community-based services, even improving access to specialty care, into a payment and delivery model which would allow for more comprehensive care and better meet the needs of vulnerable patients. We've seen ACOs gain traction in the Medicaid marketplace over the past several years due to their potential to improve outcomes and reduce costs for the Medicaid population. And given the lack of CMS guidance and other technical assistance available to states in this area, we see the work of CHCS as being very critical to furthering the development of ACOs in Medicaid and highly instrumental in helping states realize the potential ACOs hold to improving care and reducing costs for Medicaid populations. The ACO Learning Collaborative has helped several states achieve impressive results since its inception and has really helped to inform states in both implementing the basic ACO building blocks, making key design decisions to better serve Medicaid beneficiaries, Medicaid providers, and help adapt to the Medicaid-specific market environment, and assist states with issues such as developing accountable care payment methodologies, and really thinking through issues that are particular to meeting the needs of Medicaid providers and patients. And resources from the collaborative have not only helped participating states, but have also been disseminated much more broadly to other states to inform the development of Medicaid ACOs on a national level. On today's webinar, we hope to share with you some of the lessons learned from states that have been actively working on their Medicaid ACO programs, not just in terms of how they've established their programs, but how their work has been able to start to improve care, contain costs, and improve population health for Medicaid beneficiaries, and how they've been able to begin to realize some of the tremendous promise of the ACO model for improving care of Medicaid beneficiaries. So thank you again for joining. Thank you to all of today's presenters and to CHCS for continuing this important work.
Thanks so much, Pam. So I'm just going to briefly kick things off by placing Medicaid ACOs in the broader health policy context. Most attendees here are probably well aware that, broadly speaking, ACOs are entities that are held financially accountable for the total cost of care and for quality outcomes of a defined patient population. And they were created as a means to move the healthcare system toward the three-part aim of reduced healthcare expenditures, improved health, and better patient experience. When the ACA was passed in 2010, Medicare was authorized to adopt this model, building on early efforts that were already cropping up among commercial payers and providers. And soon thereafter, Medicaid, the state of Colorado, launched its first Medicaid ACO effort in 2011 with its accountable care communities. Since then, ACOs have been widely adopted across commercial, Medicare, and Medicaid payers, and they're one of the leading models of payment reform and care delivery transformation out there. As you see from this slide, there are now over 800 ACOs in the U.S. striving to improve care and lower healthcare costs for 25 million consumers. And at this point in time, there's widespread penetration, with all 50 states and D.C. having at least one ACO in their markets. Regardless of what the broader policy changes lie ahead at the federal level, there's clear momentum for ACOs, and policymakers and healthcare industry experts expect that ACOs will continue to expand their presence. ACOs are receiving a high level of cross-payer interest and support and are viewed as a key vehicle for shifting provider payment from volume-based incentives to value-based incentives, where providers have financial incentives for improving quality while lowering the total cost of care. ACOs have helped Medicare achieve its goal of having 30% of payments tied to alternative payment models in 2016, and with the recent passage of MACRA, providers treating Medicare patients are increasingly incentivized to join certain types of ACOs that will qualify as advanced alternative payment models. Early evaluation finders from researchers at Dartmouth and other institutions indicate that ACOs provide care that is more focused on population health, more focused on wellness and disease prevention as well. And early quantitative analyses demonstrate that many, though not all, ACOs are bending the cost curve and improving quality of care. So what do ACOs look like in Medicaid? Unlike Medicare, where there's been several specific and well-defined models, Medicaid agencies and individual states are provided tremendous flexibility to define ACO requirements and standards that are designed to meet the needs of their specific patient population and the market dynamics that are unique to their states. Therefore, there really is no single specific definition of a Medicaid ACO. They vary from state to state. Nevertheless, Medicaid ACOs are defined by a common set of characteristics that are tailored to meet the needs of low-income, working-class populations served by the program. Foremost is the idea that providers are financially accountable for face-to-face care management and care coordination across all of the patient's health care needs for an attributed set of patients. Payments in the Medicaid ACOs go beyond fee-for-service and reward providers to improve quality while lowering the cost of care and reducing waste. Providers are expected to form broad collaborative networks that include a range of specialties as well as broader community organizations, and to share information to a degree that we typically don't see in the current system. ACOs are held accountable for robust quality measurement of outcomes, not just processes, and across conditions that are prevalent among their attributed population. And Medicaid ACOs must look beyond the health care delivery system and are beginning to address the social determinants of poor health that may have a more direct impact on the health care costs of the patients that they serve. In Medicaid, we generally see at a very high level 3 different types of ACO models emerging. There's the provider-driven ACO model, which is closely aligned with the Medicare models. We see states like Maine, Massachusetts, Minnesota, New York, Rhode Island, and Vermont have adopted this type of model to their specific state needs. It's an important feature worth noting that the level of multi-payer alignment is key because it makes it easier for providers to participate in these models and really engage in care delivery transformation when all payers are marching to the same drumbeat. States are also using MCO-driven models or managed care organizations, where those organizations may bear the full risk but partner closely with providers to improve care delivery in innovative ways while managing the full budget of a patient's care. The third model that we see in states like Colorado and New Jersey are regional partnership models, where regional or community organizations form their own care teams and then work with providers at a community level to improve care and share incentives. On this map, you'll see what penetration of the ACOs look like in Medicaid. Right now, there are nearly 3 million Medicaid beneficiaries covered by ACOs. 10 states have ACO programs in place, and another 10 are pursuing ACO programs. I think it's worth noting that this map only reflects states that have a formal ACO program. So there are other states, such as Arizona and New Mexico, that have Medicaid ACOs that are simply contracted directly with their Medicaid managed care programs and aren't part of an official ACO program per se, but it's important to note those exceptions. So we'll get into this a little bit more with our speakers, but I just wanted to share how in our work we see Medicaid ACO programs evolving over time. First and foremost, we see the financial models evolving to really go beyond what may be an initial pay-for-performance or upside-only shared savings arrangement to eventually include upfront capitated payments that enable providers to make the needed upfront investments. Many ACO programs are also that began just by covering physical health are now evolving to expand provider responsibility for services such as behavioral health, long-term supports and services, dental care, and even social services, recognizing that in order to really drive the total cost of care down and improve outcomes, care needs to be coordinated across all of those service areas. Medicaid agencies are increasingly in tune with the need to align these programs with what other payers are doing. So what we're seeing is an evolving landscape where there's greater and greater alignment and more explicit participation among ACO providers that cut across Medicaid, Medicare, and commercial lines. States are also balancing the need for comprehensive quality accountability across the benefit of selecting a few measures that will truly drive the transformation of care. Accountable care models require robust measures that drive meaningful change, and so there's a lot of experimentation going on around what's the right type of quality measurement set that is going to truly get providers' attention, is going to really drive change on the ground, and is going to have the most impact on the efficiency of care delivered. So all of these, I think, are issues that we're going to get into later today with our panelists. So just in conclusion, I just want to share with folks some information about the program that we run here. To date, we have helped 10 states launch their ACO programs, and we're currently working with 8 states that are pursuing ACOs and Medicaid. And we also have a Medicaid ACO Resource Center that's online, providing resources to states, but other interested folks who want to understand more about how to design these programs and emerging lessons and evaluation results to date. So with that, I'm going to hand it over to our first speaker, Matt Spang with the Minnesota Department of Human Services. Matt?
Thank you, Tricia. I really appreciate that opening. I think I'm going to try to call back to a number of different concepts that I think you've already laid the groundwork for that we're looking for in the Integrated Health Partnership program here in Minnesota, which of course is our Medicaid ACO. So if you could switch to the next slide. What I think would be really helpful is just to give folks on the call some idea of what the context here is within Minnesota and our Medicaid program, because really the makeup of our Medicaid program was an important factor in why our model is in many ways what it is. So some of the nuts and bolts, and I won't read off all of these pieces, so take a look at this, whatever you're interested in, but we do have about 1 million enrollees, and the vast majority, about 85% of our enrollees in Medicaid or Minnesota Care, which is a subsidized program for us, are in a managed care organization setting. And so we'll talk a little bit about what that means, but that creates a bit of a really interesting dynamic that we manage here in Minnesota that I think allows a lot of the creativity. The other piece to highlight here on the bottom, you'll see that within our IHP program, we're really focused on those under 65 non-dual eligible beneficiaries, and again, both in the managed care and in the fee-for-service universe. Next slide. So, as is often the case, really good healthcare reform, really good products in these types of areas and payment, the ways of being innovative in payment really is reliant on what came before it. And so what I wanted to highlight here is that in Minnesota, we were very fortunate that we had a number of different pieces in place already that allowed us the framework to build our accountable care organization model. And that includes healthcare homes, a number of e-health initiatives. We were already collecting encounter data for managed care organizations. We have standardized quality metric system called SQUIRMS, or the Statewide Quality Reporting and Measurement System, which is my favorite acronym. And we have a number of different initiatives and reforms that had already preceded us when we even received our authority in 2010. So that when we began development in 2011 of what that model was going to look like, we had a lot of nuts and bolts in place, which was fortunate. That allowed us really to focus more on what we wanted, establishing that we clearly want better care, lower costs, rather than really specifying all of those hows, how we wanted to see that, and not needing to be terribly prescriptive, in part because, again, we already had a lot of that framework in place. And so we wanted a common framework of accountability, but still having tons and tons of flexibility, which has been really positive, but also can be kind of a fun challenge as well with our staff. So next slide. So I wanted to this will be kind of a bit of a whirlwind tour, although I think for many of the people on the phone call, the model components won't seem terribly foreign. But again, just wanted to run through the components fairly quickly and high level. The first, as I mentioned, are eligible recipients. We're really talking about that non-dual under 65, both in the fee-for-service and in the managed care enrollment environment. And clearly we're using a retrospective attribution, which I think is a very common model in accountable care organizations. So there's not much more. But again, really wanted to highlight that it was important to us that we were covering the widest population possible with the data available that we had in-house and from managed care organizations. So as I mentioned on that flexibility side, when we're talking through provider requirements, we knew that we wanted to be broad in the net, if you will, of provider participants in our ACO model, in the Integrated Health Partnership model. And so at the top of it, we created two general types of models. We call them virtual and integrated. The integrated are really those a little more robust medical systems, medical groups that have their primary care focused, but they still have embedded within them specialty services, hospitals that are part of the model or the system as a whole, so they have a lot of control over where their patients may be going. And so for those, we basically wanted to see movement from year 1 through year 3 in the initial 3-year period that these contracts take place, moving towards reciprocal risk so that by year 3, they have as much upside as they have downside risk. For the virtual, which are really any systems that aren't integrated, and they come in a wide variety of makeups. These are systems, they can be independent medical practices that want to participate, they can be the collaboratives, where maybe they're regional collaboratives, we have a couple of those, collaboratives across FQHCs, or just partnerships between different models. And all of those obviously are very different, but we put them in the same bucket of quote-unquote virtual, which another way would just say non-integrated. And for these models, they are only participating in an upside shared savings structure. So one of the things, and as Tricia mentioned in one of her slides, there was sort of those 3 types generally of Medicaid ACOs. In many ways, you could argue that in Minnesota, we have at least 2, if not all 3 of those in operation, which creates a lot of kind of fun opportunities, I think, and challenges here in the state. So that brings me to the payment and quality model. So, of course, again, very similar to other ACO models, we have a defined core set of services, and this includes the vast majority of services that, whether primary care or specialty services. We do exclude certain services, however, and then it's generally your long-term care or dental services and a handful of behavioral health and chemical dependency services. And our initial thinking on that was that we really didn't want to hinder providers from wanting to take the opportunity and kind of take the step with us into this accountable value-based model by putting them on the hook, if you will, for services that maybe they had less control over for their patients. I think since establishing our first IHPs in 2013, we've come to see that there's a lot of opportunity in those services that are currently carved out of our core set. And we'll talk about that in a couple more slides. The other piece, of course, there's gain and loss sharing payments that are made annually, and they're based on a risk-adjusted total cost of care performance. The basic way to think about this is all things being equal, we would expect you to cost this much. And if you end up costing less, you have an opportunity to share in that savings. If you end up costing more, you may have to lose some of your savings. And each of our HPs is really able to identify some flexibility within that general framework. So they can choose which level of risk they want to take on. If they're upside only, obviously they tend to take all of it. If they're upside and downside, so reciprocal risk, they can say that we want to cap it at 10% above or below the benchmark, or really any number, and so that allows a lot of flexibility there. And all of our IHPs are contingent on quality performance. In the first 2 years, it's 25% of any of their shared savings. In year 3, it's 50%. And one thing that's really important to highlight is that while our quality core measures are based on our statewide quality reporting and measurement system that I had mentioned earlier, IHPs are really able to offer alternative measures and negotiate with us on which measures they're really going to be held accountable for, making sure that we can find measures that really fit their target population while fulfilling the needs and the priorities of the state here in Minnesota. The last piece, and this is really critical, is that we found you can't simply just establish accountability. You do have to try to help your providers that are participating succeed. And so this comes in a couple of big ways. One is through data analytics and reporting feedback support. And so on a monthly basis, we provide claims level and patient level data to all of our participants, and it cuts across our fee-for-service, our managed care beneficiaries, and it shows them services whether they as a provider were the one that provided that service or if that patient got a service through another provider. And so that creates them, kind of opens the door for access to care that they didn't have previously in the state, and is a huge benefit and allows them to really craft their model more effectively. The other piece is that we really want to make sure that there's a lot of peer learning between the IHPs, and so that's something that we have ongoing on a quarterly basis, and then on an annual basis we meet in person, so it ends up being really quite an important piece of the whole model. Next slide. So this gets to probably the gist of the whole thing. How are we doing? As I mentioned, the very first set of IHPs started in 2013, and we started with 6 ACOs, which covered about 100,000 beneficiary lives. Currently, as of January 1st of this year, we've now grown to 21 IHP participants, and that's covering over 460,000 Medicaid lives, which is really an amazing growth, kind of a frightening growth at sometimes, just given the level of effort that's involved. We do have a goal that by next year we'll have about 500,000, half of our Medicaid enrollees in one of these models, and I'm pretty confident that we will be reaching it, if not beating it by quite a bit. Other pieces to highlight is that we've had a couple of rounds that went through their initial 3-year cycle and have chosen to rejoin up for an additional 3-year cycle. So that shows, I think, that there's a lot of value seen in our model by the provider community. We did see significant savings. In the next slide, I'll show you some more specific information about that. But a couple of things to highlight is that we have seen really what I would call the correct services by the correct providers in the correct setting is one of the big keys to the success in our model. And we've seen that through a 14% reduction in inpatient with 7% reduction in ER visits. So we're seeing a lot of efforts that are coming to fruition there. Also, all of our IHPs have been very successful on their quality side, either beating their peers or achieving improvement goals that they have in our contract. Next slide. So here's where we get this nice colorful chart. We show that we have had savings, and that savings have increased over the first 3 years. The next set of savings for 2016 will be calculated in June, so we're a few months off from being able to see that. But we've seen accelerating savings throughout the participants or across the years, as well as a growth in who's participating. So that's been a very good success. Initial looks at 2016 do suggest that we might be seeing some slowdown in that savings, which could suggest that there's a lot to squeeze, if you will, in the first couple of years. And then after that, there becomes a little harder to get more savings benefits as these models mature. But that's part of what we're kind of looking at this point. And the total amount of savings that we've had in the first 3 years was over $150 million, which we're very proud of. So the next slide, please. So here's where I think it gets to, we've seen some savings, we've seen growth in the participants, everything is wonderful and hunky-dory, right? Of course not. There's always improvements and there's always ways to continue to move the model in the right direction. And so we've reached out to IHPs and other stakeholders through an RFI process, through ongoing meetings, and these are generally what the feedback has said. The first is that, of course, we're accelerating care delivery innovations. It's great. That flexibility really allows us, and the data that we provide allows providers to focus on super utilizers, et cetera. But there is some questions on the long-term sustainability, that shared savings may be several years away, and there's a lot of upfront costs that these systems are putting into the model. which could limit who can participate and can also make it difficult if they don't see shared savings even in the first couple of years to keep that activity ongoing. So how do we address that? The second is that the data and reports have been essential. I think one of our IHPs described it as the most beautiful data they've received, which I don't fully understand, but I absolutely love hearing. But while this makes all of our IHPs much more data rich, sometimes they're still information poor. I think I heard one IHP describe it as we went from data poor to data rich, but now we're information poor and we're knowledge destitute because we're still struggling and trying to make sure that we can fully understand and utilize the data that the state is providing. It's a good problem to have, but it certainly is still a problem that we're looking at. Flexibility of the model is huge, but not all of the provider models that exist within our state really fit well, even into the two macro models under or macro models. I guess I don't want to confuse it with macro. But even under the virtual and the integrated models with a lot of flexibility, some just don't fit, and that's part of a challenge of trying to, how do we pull them into the value equation here in the state? And the last one is that while partnerships are certainly critical to the success of the model, it's very difficult to understand and figure out and create the right incentives to pull the right partners into the value equation, into the ability to gain on shared savings, to having really line of sight on the activities that are taking place with the patients. Beyond data sharing can be a challenge, but even beyond that, there's a lot of those issues that we continue to struggle with. So, next slide. So we're now, in very imaginative fashion, we're working on IHP 2.0, and I think we'll have some time to talk a little bit more about it later, but we are focused on a handful of very specific areas that we want to see when we do eventually launch what we're calling the 2.0 model. And our hope is to launch it in January of 2018. So we're all working feverishly fast here in the state. But the first is developing a prospective payment that the providers can receive near the beginning of their participation so that not all of the savings comes at the end. Clearly, there's a lot of issues we need to figure out there. The second is developing robust electronic clinical event notifications, such as admits, discharge, and transfer notifications, which our IHPs have highlighted as just being hugely important for them. The third is that we have, while we do kind of encourage partnerships with community sports, as I mentioned in my last slide, those partnerships haven't necessarily developed in the way we'd hoped. So we need to encourage those even stronger and really create more of an incentive to pull those community supports and social services in more effectively. The fourth area is that some of our models or some of our participants really aren't able to take on much risk. So we want to be able to pull them into the value equation, but maybe not with taking on any of the risk that even a virtual model has by virtue of needing to put upfront costs and infrastructure payments towards it. The second to last one here is that there are some of our models that want to take on even more risk, sort of the opposite of that last point. And so we're trying to figure out how to accommodate in many ways both of those points in creating a model that's more of a, maybe it's global or it's a global budget or it's capitation based, but something that's a little more robust in that sense. And the last piece is that we need to make sure, while we've tried our hardest in the initial development of our model, we want to continue to make sure that we're aligned with our state's healthcare homes, as well as what's coming down the line through MACRA and any other programs that maybe the MCOs are having in each of those pieces within our 2.0 model. So we, of course, have a very easy path ahead of us and are very much looking forward to it. So thank you.
Thank you so much, Matt. That was terrific. I'm going to turn now to Chris Tamar, Director of Systems Innovation at the Transformation Center at the Oregon Health Authority. Chris?
Yeah, thanks, Tricia. Today I'll be sharing a high-level overview of Oregon's delivery system reform efforts, the performance we've seen so far in the areas of quality and cost, and then lessons we've learned through implementation. So next slide, please. Oregon's been working toward reforming its healthcare delivery system for well over 5 years, but the official reform that I'll be talking about today occurred in 2011 when there was strong bipartisan legislation led by the previous Oregon governor, who was also a doctor and had spent years advocating for delivery system reform. The 2011 legislation proposed coming up with a plan to develop a statewide system of what we call coordinated care organizations, or CCOs, which are essentially a Medicaid ACO model. CCOs are networks of all types of physical health, addictions, and mental health, and dental care providers who work together to serve Oregon Health Plan or Medicaid members through implementing what we call the coordinated care model. After the 2011 legislation passed, there was a whirlwind of activity in 2012 to get the system in place. So first, the Oregon legislature passed additional legislation that approved the plan that was developed per the 2011 legislation. Most of our 16 CCOs were launched just a few months later. And then also the Oregon Health Authority leadership worked with the Center for Medicare and Medicaid Services to update our 1115 Medicaid waiver, which gave us the authority to implement our CCOs. Next slide, please. So as I just mentioned, CCOs are implementing what we call the coordinated care model. While we started implementing the coordinated care model with our Medicaid population, this is actually a model that can be and is being adapted for other populations. So you see the 6 components of the coordinated care model here. Separately, these elements all help to lead to the triple aim, or better health outcomes at lower cost, but used together, their effectiveness is increased. So later in this presentation, I'm going to be talking about the 3 components that you see on the right side, which are paying for outcomes, sustainable rate of growth, and measuring performance. The model also focuses on engaging the patient to support shared responsibility for health and providing incentives for preventive care, such as low or no-cost screenings or well-child visits, transparency in price and quality, which includes transparency in provider performance, and evidence-based best practices to manage and coordinate care. Next slide. So this slide shows how CCOs are implementing the coordinated care model and kind of what the delivery of care looks like before CCOs were in place under our Medicaid program and what it looks like now. So the first row shows that how the CCOs coordinate their members' physical, oral, and mental health care instead of the fragmented care delivery that used to exist under Medicaid. Second is, per our 1115 waiver, Medicaid pays CCOs a global budget that includes payment for services in these 3 areas. In addition, Oregon's Medicaid spending is kept to a maximum of 3.4% growth a year, which is 2 percentage points lower than the 5.4% national average rate of growth in Medicaid spending that was in place the year our waiver was put in place, or 2012. The third row, I'll be discussing this a little later, the metrics incentives that we have in place. The fourth is flexible services. This is an innovative component of Oregon's waiver, which allows for services to be covered that promote health but are not traditionally covered Medicaid services. Examples of these are gym memberships or gym shoes, short-term rental assistance, cooking classes, or services that would support the health of a CCO's entire community, such as mental health services in a local school that are available to both Medicaid and non-Medicaid members. CCOs are also required to focus on the health of their entire community. Each CCO is responsible for developing a community health assessment and a community health improvement plan to guide their work in support of everyone in their geographic area, not just their Medicaid members. Once again, a difference from what care looked like before CCOs were in place. And then finally, each CCO is locally governed. For example, according to statute, each CCO must have what we call a community advisory council to ensure that the health care needs of the consumers and the community are being addressed. The CAC, or Community Advisory Council, must include representatives from the community and each county government that's served by the CCO. But in addition, and very importantly, Medicaid consumers must represent a majority of the Community Advisory Council. The Community Advisory Council also oversees implementation of the Community Health Improvement Plan I just mentioned before. Next slide, please. So this is a map of Oregon, which shows how the 16 CCOs coverage areas differ, or what they look like in Oregon, and you can see how they differ. As you can see, they vary in size substantially. For example, the orange on the right side of the state is one CCO, which covers the entire eastern part of Oregon. In most areas of Oregon, there's just one CCO available, although in two, one is the Portland metro area, and then also in southern Oregon, there is some overlap across CCOs. So I'd also mention that about 90% of Medicaid members, or our Oregon Health Plan members, are covered by CCOs, and the Medicaid population in total in Oregon is about 1.1 million people, which is a quarter of the Oregon population. Next slide, please. So I run an entity called the Transformation Center, which is a key strategy Oregon uses to foster innovation happening through the CCOs. The Transformation Center was launched in 2013 through our State Innovation Model branch from the Center for Medicare and Medicaid Innovation. The centers, we call ourselves the hub of innovation and quality improvement for Oregon's health system transformation efforts. We provide support at the provider, the system, and the community level. Over the last 3-4 years, we've overseen hundreds of learning collaboratives and technical assistance efforts to support delivery system reform in a whole host of areas, from value-based payment to behavioral health integration. Next slide, please. So now I'll be talking a bit about how the CCOs are doing. I'll be talking about metrics, and then also be talking about cost performance. So as I mentioned earlier, one of the key components of Oregon's coordinated care model is paying for outcomes and measuring performance. For CCOs, we incentivize and measure performance in 2 different ways. First, we have 33 state performance measures that we're required to submit to CMS in conjunction with our waiver. There are financial penalties to the state if we don't achieve the quality goals related to these performance metrics. And second, we've developed 17 incentive metrics or measures for CCOs. Every year, we set aside a certain percentage, and it's been increasing every year. It's currently 4% of the global budget that the CCOs receive. And if they meet performance goals that are set in conjunction with these incentive metrics, they receive funds back through what we call a quality pool. We found that these incentive metrics are been a significant driver of behavior change and really led to positive change in regard to outcomes. So in the next few slides, I'll give some examples of the CCO performance on some of their incentive metrics. Next slide, please. So enrollment in a patient-centered primary care home is one of the 17 CCO incentive metrics. As you can see from this slide, enrollment has increased by almost 75% since 2012. This is especially impressive considering CCO enrollment has increased more than 60% due to Medicaid expansion we put in place in 2013. So CCOs have had to work really hard to ensure that their members, these new members, are enrolled in a patient-centered primary care home. I also want to take a moment here to note that our patient-centered primary care home program is showing significant return on investment on its own. A recent study, which is conducted by Portland State University, found $13 in savings in other services such as specialty care, emergency department use, and inpatient care for every $1 spent in the patient and primary care expenditures related to our patient-centered primary care home program. Next slide, please. This slide shows that avoidable emergency department utilization, which is another CCO incentive measure, has decreased 53% since the baseline year of 2011. We've done some investigating with CCOs to identify how they've achieved this impressive result. And most of the success is related to CCOs targeting their services on high utilizers. For example, one CCO added health workers like peer mentors, and community health workers to an interdisciplinary team that focuses on the CCO's 15 to 20 members who live with chronic illnesses and were frequent visitors to the emergency department. During the first month of implementing the program, this CCO saw a 50 to 60% reduction in emergency department use. In one case, one member who had made 70 visits to the emergency department over 1 year made just one visit during the 6 months following the implementation of the program. Another CCO uses a combination of care coordinators and health information technology, specifically 2 relatively new complementary HIT solutions that Oregon has put in place. One is called the Emergency Department Information Exchange, and the other is called Pre-Manage. These approaches, they work together to provide real-time hospital notifications about patient visits to providers across the health system to reduce avoidable hospital use and improve health outcomes. This particular CCO had a patient with a history of extremely high ED use, 23 times in 1 month. One of the CCO's care coordinators received a real-time notification that this patient was at the ED again, met the patient and the hospital social worker at the emergency department to provide assistance related to the patient's many needs, some of which were related to medication management and others that were related to problems outside of the healthcare system that required supportive social services. After receiving these interventions, this member's ED visits have decreased substantially. Next slide, please. Another CCO instead of metric, which was added after CCOs were launched, and I'll be talking a little more about that later, that the metrics are evolving over time, is dental sealants for children. This slide shows that the percent of children ages 6 to 14 who received a dental sealant on a permanent molar over the past year has increased 80% since 2014. We're also measuring CCO metrics performance across racial and ethnic groups, and we found that sealants have increased across all racial and ethnic groups since 2014. Next slide. So I mentioned earlier that another component of the coordinated care model is a sustainable rate of growth. We've seen a success in this area with regard to CCOs as well. We've been successful in holding costs to a 3.4% growth or below the national average in accordance with our CMS waiver. We've also found that we've avoided $1.3 billion in care since 2013 through health system transformation, which is projected to save over $10 billion by 2022. Next slide, please. So I'm going to end with sharing some of the lessons Oregon has learned through our health system transformation journey, and I will note that I heard some similarities already with what Minnesota shared. So first is in the value of leadership. I mentioned that we had leaders at the governor level, the previous governor, and also our current governor are very supportive of our health system legislation. We've also had a number of key legislators in support. But then CCOs are also designed to be locally run and include the voices of Medicaid members. So there's also leadership at the local level. I've also shared examples of how financial incentives can play a huge role in driving behavior change. We found this, and I've shared this with regard to our incentive metrics. Third, per our waiver and the way CCOs were designed, they have a fair amount of flexibility and are encouraged to experiment with innovation. In addition, we found that it's important to foster a culture of innovation, which has been the focus of the Transformation Center. Some of the ways to build this culture is to support relationships across the delivery system so people are more inclined to share what they're doing and what they've learned. Then also we've taken the strategy of training people within the CCOs on the science of quality improvement so they can continue to promote innovation on their own. And then finally, and I heard this from Minnesota too, we found that it's effective to incorporate delivery system efforts that are already underway. For example, our patient-centered primary care home program was being built the year before CCOs were starting to be launched. And so we felt it was very important to build in the PCPCH model within CCOs, and I shared in an earlier slide how that's being done through an incentive metric. So thanks for the opportunity to share the exciting work happening in Oregon, and I look forward to answering more questions at the end.
Thanks so much, Chris. That was a great presentation. I'm going to turn now to Alicia Cooper, the Healthcare Project Director at the Department of Vermont Health Access, to share information on results to date and lessons learned from Vermont's program. Alicia?
Thanks so much, Tricia. I really appreciate the opportunity to be able to tell everyone a little bit about the Vermont Medicaid Shared Savings Program and some of our early experience. Next slide, please. One more. So I'll start with a little bit of historical context for the establishment of our Medicaid Shared Savings Program in Vermont. In 2013, Vermont was awarded a $45 million SIN testing grant from the Center for Medicare and Medicaid Innovation. And with this funding, Vermont launched its Vermont Healthcare Innovation Project. Among the objectives of the project were to design, implement, and evaluate alternative multi-payer payment models in support of the triple aim. So out of this, one of the key programs that was launched early on was a Medicaid Shared Savings Program. This was part of multi-payer efforts and was done in alignment with commercial payers in the state who were establishing on the same time frame a commercial shared savings program. And these were in response to the offering of the Medicare Shared Savings Program and a number of ACOs forming in the state in response to that program being available. The Department of Vermont Health Access administers the Vermont Medicaid Shared Savings Program, and it was designed as a 3-year program that began in 2014. Next slide, please. The Shared Savings Program standards in Vermont, as I mentioned, were developed collaboratively among both the public payers and the private payers in the state, alongside other stakeholders, including the provider community and the ACOs. And a lot of the early conversation in the design of the shared savings programs focused on certain elements, including how members would be attributed to an ACO, how expenditure targets would be established, how savings would be distributed, the impact of performance measures on the distribution of any savings, and how ACOs would be governed. And as I mentioned, this conversation happened largely in response to the offering of the Medicare Shared Savings Program, so there was quite a bit of alignment early on in the development of our Medicaid and commercial shared savings programs in Vermont. Next slide, please. To start with a brief overview of how we considered attribution, like some of the other presentations we've heard earlier, we're looking at a retrospective attribution methodology, and not all of our Medicaid members in Vermont are considered eligible for attribution to an ACO. We define our eligible members within 3 broader eligibility categories. We've got one for general adults, one for general children, and then a category for aged, blind, or disabled adults and children. From the attribution, we exclude anyone who's duly eligible for Medicare and Medicaid because those lives are often participating through the Medicare shared savings programs that are operational in Vermont. We also exclude individuals with coverage through commercial insurers or individuals with any evidence of other third-party liability coverage. And we exclude individuals who are enrolled in Medicaid but who receive a limited benefits package. An example of this would be an individual who received pharmacy-only benefits through Medicaid, making sure that we have as good an alignment as possible between the services for which an ACO is accountable and the services that a member who is attributed is receiving. Next slide, please. So in order for a member to become attributed to an ACO under our shared savings program, they keep seeing their primary care providers as they usually do. If the PCP belongs to one of the participating ACOs, the ACO can then share in any savings based on the cost and quality of services that are provided to that particular member. So it's essentially a passive attribution process that is occurring retrospectively. So at the end of a performance year, we'll look back 12 months to see where each member has had the preponderance of services during the year, and that's what we use to determine where an individual would be attributed. Under this model, it's still based in fee-for-service reimbursement, so providers continue to bill as they normally do and are paid as they normally would have been absent the ACO model. The only difference to the payment structure comes at the end in the form of a potential incentive payment. Next slide. So one of the things that we've contemplated on an ongoing basis through the course of our program's design and implementation is which services would be included in the ACO's total cost of care and which services would be excluded. In the interest of aligning early on with the services that were included in the total cost of care for the Medicare program and for the commercial program that was developed simultaneously, we primarily focused on including services that are listed on this slide, such as inpatient and outpatient hospital services, physician services, nurse practitioner services, FQHC, home health, and hospice services. There are a number of examples of the services that are excluded on the other side of the slide. Key among these are pharmacy, dental, long-term services and support, non-emergency transformation, and any services that are delivered or paid for by other departments within the Agency of Human Services that are not the Department of Vermont Health Access. Next slide, please. So this slide just shows a higher level schematic of how the shared savings program expenditure targets are evaluated relative to actual expenditure and how that results in the shared savings calculation. Essentially, for each ACO, there is a calculation done for the projected expenditure for the attributed population of members for each program year. At the end of the year, if actual expenditure is less than what had been projected for that ACO, then that's what is considered the savings, the difference between the projected and the actual. Contingent upon the ACO meeting certain quality targets, the ACO is then eligible to share in the savings, the difference between the projected and the actual, with Medicaid. And the savings split is dependent upon the overall quality score. So it might vary from ACO to ACO from year to year depending on performance, but the root model is a 50-50 split. In the first year of our shared savings program contract, we established a two-track model for participating ACOs in which they could opt to have either upside sharing only or upside and downside risk. The ACOs participating in our shared savings program opted for the upside sharing only model. We also had some options throughout the program's contract life that would have allowed for differences in the sharing rate over time, but the way that decisions were made by our participating ACOs throughout the course of the program, it did maintain the structure of 50-50 sharing for the base depending on quality performance. Next slide, please. So here we highlight some of our 2014 and 2015 program results. We do have two ACOs who have participated in our Medicaid shared savings program since the beginning in 2014. And those two ACOs are highlighted in the first column of this slide. Over 2 years, the net aggregate savings amount to about $15.7 million. And over the 2 years, we've also observed improvements in quality scores. And these summary level scores are reflective of approximately 79,000 Medicaid members in Vermont being impacted. So some of the key takeaways were that both of our ACOs saw pretty considerable savings in the first program year. In the second program year, only one of our ACOs saw savings, and the other did not. And we do also observe over time pretty notable increases in the overall quality performance of each of the ACOs that has been participating. Like some of the other presenters have noted, we are anxiously awaiting the 2016 program results. The program year has now concluded, but we expect that the results won't be finalized until probably the third quarter of 2017. Next slide, please. And one more. So as we look forward, we are contemplating a number of alternatives for evolving our shared savings model going forward. We have seen some early successes in the shared savings model, but as we are observing and as other programs across the country have observed, there can be diminishing returns for ACOs participating in a shared savings model as the model grows over time. So what we are looking to do, yet again inspired by Medicare's ACO program offerings, is to develop a model based on the Medicare Next Generation ACO program for Vermont's Medicaid ACOs. We would imagine ACOs in this new model being paid a prospective, all-inclusive population-based payment for the suite of services for which they would be responsible. It builds off of the Medicaid Shared Savings Program, as I mentioned, but the goal is to increase the amount of flexibility that providers would have in determining how best to maintain the health and well-being of their attributed population, and to increase the move from fee-for-service reimbursement toward more meaningful value-based payments. And I believe that that is all I've prepared for today, but I certainly look forward to answering additional questions in the discussion as well.
Great, thanks so much, Alicia. So this is Tricia, Center for Healthcare Strategies. We've already gotten a few questions over the chat box, but again, just a quick reminder for folks. If you, we're going to turn to the Q&A portion of today's webinar, so if you have questions, please submit them in the chat box as indicated on this slide, and we will do our best to get and cover as many questions as we can over the next 30 minutes. So I'm going to start off with a question for all of the states. And it's a pretty high-level question, but pretty central to the programs and some of the keys to your success. What are, from each of your perspectives, what were the key policy goals and objectives that your ACO programs have enabled you all to achieve? And what do you think have been some of the key drivers of your success that other folks might be interested in? So I'll just go in order maybe at first, and maybe start with Matt on that question.
Sure, thank you, Tricia. Yeah, I mean, I think the big driver was to move providers in the direction of value versus just fee-for-service, paying for each of those, and to really be a big part of the acceleration of that movement in the state. It's part of the reason why we wanted to have a wide spectrum of Medicaid beneficiaries, both fee-for-service and managed care, to be part of our IHP ACO model. I'm sure with any providers on the phone, and I'm sure I know in other states, there's kind of this phenomenon of a tipping point for a provider to make the decision to move towards more of this value-based operations, primary sort of PCP, primary care model, where if it's a small subset of their population, it's just not necessarily worth the incentive, the investment, some of the time and energy that they have to put into it. So we really saw that as being one of the overt goals, and I think we've seen some really good movement in that way through the growth now that we have 21 participating, and many of the largest, most of the largest systems in the state are part of our model. Part of what I think allowed us to do that was we made it worth their time. We make it worthwhile, even if there's no guaranteed shared savings in a model like this, and there certainly isn't. The data, the support, those pieces, the collaborative relationship that we've established with them, I think highlighted that we were going to be able to help them make that leap over to more value-based, and we were going to be kind of providing them with some support that will let them do that, so that it makes that step a lot easier. So I think those were kind of some of the big keys, as well as all of that, as I highlighted, the foundational pieces that we already had in place. Without those, I don't think we would be nearly as quick moving and successful as we have been in the state.
Great. Thanks, Matt. Chris?
Yeah, so I think that Oregon's primary goal was really to design a system that would promote health and not health care. So really looking at the triple aim as our kind of goal, but the essential piece of it is that health piece. And the leadership that developed our coordinated care model and put CCOs in place contended that there's a sufficient amount of money in the system. We just need to change the way we deliver care. So the coordination of care that's built into our model, paying with a global budget, allowing for flexibility, and also the flexible services component that I mentioned earlier, and I would say the incentive metrics piece are all major keys to the success. I think other thing, I would echo what Matt just said around value-based payment and allowing for flexibility around payment. In Oregon, we've definitely seen some movement in that direction, that CCOs are taking their global budget and paying their providers in an alternative way, but we also know we want to go further with that, and so that's one of our goals moving forward. And then I think that's the last thing I would say is in conjunction with promoting health, not health care, is really allowing for the ability to support the social determinants of health and allow for kind of that, the connections with the community, connections with other partners that will promote social determinants, not just, once again, the provision of health care.
Thanks, Chris. And Alicia, your thoughts?
So one of the key objectives for Vermont when it embarked upon its SIM grant work was to make progress toward multi-payer payment reform. And I think that our ACO program has allowed Medicaid to align pretty meaningfully with commercial payers in the state and with Medicare in the overall design and implementation of our shared savings program. Because the design features were largely modeled after the Medicare program and in conjunction with the commercial program, Vermont's ACOs have had 3 pretty comparable programs in which to participate during the last several years. One of the major enabling factors for this alignment was early establishment of multi-stakeholder work groups who were tasked with the development of program standards, quality measures, and with making related policy decisions throughout the implementation phase. These work groups fostered pretty robust conversation and ensured that diverse perspectives were included in the planning and decision-making from the very beginning. I think that this has positioned us well for future multi-payer payment reform efforts, and a precedent has been set for this kind of collaboration and work toward alignment going forward.
Great, thanks, Alicia. I have another question for everyone, really, that came across the chat box. And this is, each of you have hit upon this a little bit, but just delving in a little bit more specifically, just describing or providing examples of the very specific services or areas that have been the key drivers of cost savings that you all have seen under this program. And any comments that you all can make around, what changes that you all have seen on the ground with the ACOs that you're working with that may have resulted in some of those service area improvements, and any sort of anecdotal evidence that you see on really what the ACOs are focusing on that enable them to achieve cost savings in specific areas. So I'll just do a round robin again, maybe starting this time with Chris. You want to take the question first, and then I'll turn to Alicia and then Matt.
The main driver has been the emergency department use in Oregon in the slide that I showed previously. So I think that's really the essence. There are a whole host of other areas we're definitely seeing change, behavioral health integration and primary care together. We're seeing a lot of work there. I already mentioned the return on investment with the patient-centered primary care home program. That's a significant savings driver as well. So sorry not to add anything new, but I kind of picked those two for a reason in my slides, and I think those are the two areas that I would say we're seeing the most savings at this point.
Great, thanks, Chris. Alicia, how about for Vermont?
Thanks for the question. We have been doing a little bit more exploratory analysis to try to understand some of the underlying changes in utilization that may have been driving some of the savings that we were observing. And while we certainly are seeing decreases from time to time over certain categories of services, not necessarily consistent across our ACOs. And I think that speaks to the different models that each of our two ACOs have chosen to employ in their participation in the shared savings program. So we are seeing some general decreases in inpatient utilization, more decreases in inpatient utilization, some offsetting of that with additional services being used in the outpatient setting and FQHC settings. Some of the other things that were, I think, pretty notable, and in particular in our first year, was the impact of the Medicaid expansion in 2014 happening concurrently with the first year of our shared savings program, given that there wasn't a lot of data from which to make projections on the utilization for this particular population. It was difficult to know whether they would be heavy utilizers of service with new access to Medicaid coverage, or whether they would be slower to enter the system because their coverage was new. So I think we were seeing some impact of this in our first year in particular, with maybe less utilization than expected for that particular subpopulation as well.
Thanks, Alicia. Matt, observations from Minnesota?
Sure, and I think very much like what we've already heard. In many ways, we could say that there's probably, with our 21 ACOs, there's probably 21 different, in some ways, approaches towards conquering the need for really high-quality health care and health, and at an affordable cost. And we have done some initial examinations and some evaluations to try to identify, are there smoking guns, are there specific things that if you do X, you will get Y, which is these great results. And not much has necessarily emerged as purely as we would hope, but probably exactly as we expected. That said, we've had really good conversations and feedback from a number of our different IHPs, and so some of the themes that have emerged are really a stronger focus on effective care coordination on the most critical parts of their population. So the use of the data that we provide, combined with some in-house data that they may be receiving, to identify which are the patients that are going to be, that have the greatest needs for advanced care coordination and management, as well as maybe some additional services that are not currently receiving, et cetera, has been very important. This can include behavioral health. That's been one area that I think a lot of, probably half our IHPs have highlighted as being a big cost driver, is previously untreated behavioral health problems, that being able to address that in an effective way, whether it's through integration of behavioral health into their system, or partnerships with behavioral health providers where available, or looking at where maybe there's a behavioral health workforce shortage, looking at different ways of trying to telemedicine type of things, that's a really big driver as well. And tied to that are what I would say a number of our IHPs have highlighted community partnerships. And as I mentioned in my presentation, that's one area where we encourage, but we don't really have strong incentives. But we have still seen some of our IHPs be more effective with reaching out and bringing into their system at least a few of the social determinant providers that are, or services that are oriented towards some of those social determinants. For a good example is Second Harvest, which is a food availability, basically a program. We have a couple of IHPs that have been working on developing basically a food for prescription kind of system so that they can identify who needs the services from Second Harvest and then get them those services. It was very much focused on like diabetics in one area, et cetera, et cetera. So I think those are some of the really big pieces. And it's just different new ways of using the information they have and getting back to kind of that core of what are the needs of the patients and how can we deliver them, and also looking at that population, wider population level of services that maybe their areas are in need of. So there's a lot, and it's hard to say one specific thing, I guess.
Well, you've actually created a very nice segue, Matt, though, into another question that we've gotten several questions around, which is probably not a surprise to anybody on the phone, which is social determinants of health. And so I'll try to synthesize what are a few questions into a two-part question for you all, which are, one, what do you see happening on the ground with your ACOs around social determinants of health? Are there, any services in particular that ACOs appear to be getting a lot of traction around? So first is kind of on the ground, what are you seeing? And the second question is really at a programmatic level, what do you think are some of the features in your models that may be particularly supportive for prompting ACOs to begin to tackle the social determinants of health? And if there are any things you want to comment on in the future around this question, please feel free to do so. So there's a lot packed in there, but why don't I actually start with Chris on this question, because I know this has been, from the get-go, something very explicit that you all have built into the Oregon model, and then we can turn to Alicia and Matt. So Chris, do you want to kick us off on that question?
Sure, happy to. I mentioned the flexible services component of our model and kind of gave some examples. So just to reiterate that we found that CCOs are supporting a whole host of areas or supports around social determinants. So exercise and healthy eating and housing are all services that are related to social determinants of health and that we found that CCOs are supporting. So that is one area. The other area that I want to focus on as well is our incentive metrics, and I kind of alluded to this, that the incentive metrics have changed over time very intentionally. So we had a certain set, I think we started out with 17 metrics, and then over the last few years, there's a committee that decides which, it's an outside the state government process actually, or it's not an OHA committee, it's outside, that decides the metrics. And a year or two after the CCO started, they added more incentive metrics that are focused on social determinants of health. So examples are tobacco use, effective contraception, the dental sealant metric that I mentioned, and then immunization. None of those were part of our model from the beginning, and they've all been added over time with the recognition that that we want to move more toward incentivizing behavior change around social determinants of health. There's talk about an obesity-related metric. Not sure if that's going to come to pass and what that will look like, but that's just to kind of give you an example. In addition, the CCOs were given there some money, about $30 million, $27 million of which the CCOs were able to use for transformation fund projects from our legislature. 3 years ago, I believe, those funds were passed, maybe 4, were awarded to the CCOs, and they put in place a whole host of projects that were related to social determinants of health as well. So basically from various angles, the CCOs are working to support social determinants of health. I guess I'd say lastly is I did mention the community health improvement plans that every CCO is responsible for having, and the community advisory council that oversees that, the implementation of that CHIP. There are the development of the CHIP. When it comes to implementation, many CCOs are implementing the priorities that were identified in those plans. So, yes, social determinants of health, huge. We're hoping to go even further along the social determinants continuum in the future. So we're very supportive of that.
Thanks, Chris. Alicia, how do you see this question playing out in Vermont?
This is a great question. There has been a lot of really fantastic work going on in Vermont over the course of the last few years in the development of these community collaborative initiatives. What we're seeing all over the state are provider-led community collaborative teams that are developing and focusing on quality improvement based on priorities that each community identifies, and engaging in PDSA cycles to really focus on areas that are seen to be of key importance to the patient population in each given area. A lot of these collaboratives have active participation from the ACOs within the state in each geographical area, but they also have broader participation from other providers who maybe haven't historically been a part of ACOs or have been a part of ACOs but have been focused on the areas that the ACOs have not previously been responsible for. Another key activity that's come out in the last few years has been really robust work around adoption of shared care plan models that have been designed to better engage all types of community providers in addition to the primary care providers who have been more traditionally participating in our ACO programs, and to use these shared care plan models to identify social determinants of health needs for each individual who is being engaged at the community level. So this is just, you know, and I'm certainly probably not the most knowledgeable person in the state about some of this really great practice transformation work that has been going on, but it's certainly been present and growing over the course of the last few years, and our ACOs have been actively participating in this work, and I imagine that this will be the framework for growing the involvement of ACOs over time and for better addressing social determinants as we develop new models going forward.
Thanks, Alicia. I like the point that you made too around the care management plans and how having those shared pieces in place have really seemed to be a really critical factor. Matt, you began to speak about this, so hopefully you didn't steal your own thunder, but anything else you would add on the front around, you know, how social determinants of health are playing out either on the ground with your ACOs or how you all are thinking about that at the state programmatic level?
Sure, and I think it's really another one of these where it's a bit of both, and it's probably not yet sufficient in my mind and in my opinion. Hopefully I don't get kicked by anybody from my agency for saying that, but I think currently in our current model, we have a number of, like I said, we urge, we encourage, we hope that partnerships and those types of activities take place, but we don't necessarily have anything that overtly requires or very strongly incents. And so that's certainly one area that we're looking for when we go to 2.0 is requiring in some way or at least creating some sort of incentive, so there may be an additional bump if you have a partnership with a community or social service agency. Quality metrics that more effectively get at some of those social determinants of health, and possibly, if we can ever get this figured out, is how to integrate within the risk adjustment model so that we're not disincentivizing providers from taking on those that have those socially complex needs. That said, there are a few things that are taking place currently that, you know, some of them have been developed over time. At the ACO level, a number of our ACOs, our IHPs, have been participating in what was created under, the state received some SIM dollars here, and one of the things that grants that we put that towards was the development of accountable communities of health, not to be confused by accountable health communities at the federal level. And they were basically a strong incentive for the IHPs to join up with various community groups to create these ACHs here in the state. And we've seen some moderate success and I think continuing movement in that area where they have some programs. So the IHP medical partner tends to focus on diabetes programs within their community, working with various groups, et cetera, those types of things. So from a ACO-driven component, we are seeing some of that. I would say they're at the early phases in many ways, and we're encouraged but watchful. The state itself, or the agency, one of the things, there's a couple of ways we've tried to encourage or at least help in addressing social determinants even right now. So one really good example, I already talked a bit about the second harvest piece and how we've put some dollars through a grant to help some of that. But one kind of very explicit thing that we did is in collaboration with one of our IHPs, which is a major safety net provider here in the States in our metro area, we developed a homelessness indicator that basically can show whether a patient has been homeless, is at risk of being homeless now or in the past, and integrated that into some of our data, into one of our data reports that all of the IHPs receive. And we know that some of the IHPs have gone to the point of being able to integrate that into their system so that when a provider, a primary care provider, sees a patient, they can see that that's one of the socially complex needs of that individual. And so that's, I think, again, it's fairly early in its use, but it's something that we've tried to do because we saw that as where we really are adding a lot of value and can do in a relatively simple fashion right now. So I'd say that's still what we're trying to do is how can we assist, how can we facilitate while looking at what are some of those incentives more big, long-term in 2.0 onward.
Thanks, Matt. Good initial thoughts. And this is definitely one of those areas that I think we'll all see the work that you all do as well as other states continue to evolve as you all tackle this at a state level and figure out, what the best way is to support this sort of on the ground level addressing of social determinants of health. We only have 2 minutes left. We have one high-level question that I can take a first stab at, and if states want to respond, they can. And that is, how do you see the ACO model emerging or changing under the new administration? And I think from our perspective here at CHCS, I would say that, regardless of the changes that may or may not happen down the road with Medicaid coverage and financing, that really the fundamentals that are driving the use of ACO models, the fact that the U.S. healthcare system is marked by the highest cost per capita, and that for those expenditures we get pretty mediocre quality outcomes, that those fundamentals are not changing. And that ACOs are one of many promising models and strategies for tackling that. And that they will continue to evolve as we in states learn lessons and incorporate insights from evaluation findings. But we don't see this model going away anytime soon. We see it evolving to strengthen and yield more promising results over time. So I don't know if any states want to respond to that or not.
This is Chris, and I'll just really quickly say that Oregon's waiver renewal, so the next iteration of our 5-year waiver, was approved on Friday, so breaking news. And this is really exciting, and it basically will allow us to continue moving forward with our coordinated care organization model.
Great. Thanks, Chris, and congratulations. That's terrific.
Thanks.
I think you nailed it, Trish.
Okay, well, we are at time. I want to thank the panelists so much for the time and effort and just the frankness of your responses. Really appreciate it. There's a lot of good info, and I'm sorry that we didn't get to all the questions. There were a lot of really great questions that folks submitted, so we will do our best to tackle those through the ACO Resource Center in one fashion or another. In closing, thanks again to the Commonwealth Fund for supporting this webinar. And please, folks, do take 2 seconds, maybe more like 30 seconds, to complete the survey that will pop up at the end of this webinar. So thanks so much for your time and attention, and we look forward to connecting with you all later. Take care.
That will conclude today's conference. Thank you for your participation, and you may now disconnect.